Hello, everyone. So I will be talking about the pharmaceutical drug quetiapine, also known as Seroquel, which is the brand name. So quetiapine, commercially known as Seroquel, is a typical antipsychotic developed by AstraZeneca. It was approved by the U.S. Food and Drug Administration (FDA) in 1997 for the treatment of schizophrenia. So the drug emerged during a period when the psychiatric field was moving away from the first generation antipsychotics due to their high risk of um, extrapyramidal symptoms and tardive dyskinesia. So then quetiapine was part of a new generation of antipsychotics designed to target both dopamine and serotonin receptors. So it also has antihistaminic and alpha adrenergic properties. So this contributes to its sedative and hyposensitive effects. So initially it was released for schizophrenia, but then later it was approved for bipolar disorder, including manic and depressive episodes, and also it acted as an adjacent treatment for like major depressive disorder. So then quetiapine is now available for immediate release and extended release formulations. So then thinking about clinical use, so today quetiapine is still approved and used in the treatment of schizophrenia. It helps reduce symptoms like hallucinations and delusions with a lower risk of movement side effects compared to some of the other antipsychotics, especially the first generation antipsychotics. And then choosing quetiapine to help treating delusions and hallucinations is often chosen when patients also have have mood issues, anxiety, or they have trouble sleeping. So then, thanks to the quetiapine calming effect, some providers will elect to choose quetiapine as a way to treat hallucinations and delusions. While it may not be the strongest antipsychotic, it's a good option for those needing a more tolerable treatment. And so then now thinking about, and as I mentioned in my first slides, that first it was approved for the treatment of schizophrenia, and then now it is approved for bipolar disorder. So it's approved to treat both manic and depressive episodes. It helps reduce symptoms during mania by calming excessive dopamine activity. And it actually improves low mood and energy during depression by affecting the serotonin and norepinephrine. So then, because it works in both phases, it also acts as a mood stabilizer. So this can help prevent future episodes. So then, like I said, although quetiapine is approved for schizophrenia, bipolar disorders, it is also used as an add-on treatment for major depression disorder when the antidepressants alone are not enough. So some providers may elect to add quetiapine into to help somebody with major depressive disorder. And this is because it can help with sleep, anxiety, and motivation. So especially in cases where like there's some resistance, and so this quetiapine can help. And then other ways that this drug is used is that um, it can be used off-label for generalized anxiety disorder, PTSD, insomnia, like I mentioned before, due to these calming effects. Uh, but then also it requires a lot of careful risk benefits, kind of the evaluation because of the side effects that this can bring. But then also it is some providers elect to use this because of its calming properties. And so then it just makes an option for patients who are experiencing acute agitation or anxiety, but then it may be less effective for uh, severe people with anxiety or agitation. Um, I'm sorry. So I was meaning to say like it actually is less effective for severe psychotic symptoms compared to other antipsychotics like risperidone or olanzapine. So then kind of just to go back to this, so quetiapine is sometimes is used off-label for PTSD, GAD, insomnia, and this is because of their calming properties, but then they are less effective for severe psychotic symptoms compared to other antipsychotic like Risperidone or olanzapine. So just wanted to clarify that. And so then thinking about the mechanisms of action and EPS risk. So this slide explains how quetiapine works and why it has a lower risk for EPS, which means extrapyramidal symptoms. So first, quetiapine has low affinity binding to dopamine D2 receptors, so which means that it doesn't block dopamine as strongly as older antipsychotics. So that's why it causes fewer movement side effects like tremors or stiffness. And then second, it blocks serotonin 5-HT2A receptors, which helps improve mood and reduce negative symptoms like social withdrawal or low motivation. And this is especially important in depression and depression episodes in bipolar disorder. So quetiapine also has an antihistaminic effect, which contributes to its sedating properties. So this is what it makes it useful for patients who struggle with anxiety or sleep. Additionally, it blocks alpha adrenergic receptors, which can cause orthostatic hypotension. This means a drop in blood pressure when standing up. So then this is why quetiapine is important also to kind of for like kind of the risk and the side effects. And then finally, while APS symptoms like tremors or dystic akathisia are possible, they are considered rare with quetiapine due to that weaker dopamine blockage. And so then, as I mentioned, quetiapine is atypical, which means that it was created in 1995 and it first was approved for the use of bipolar in 2004 and then later on for uh, bipolar regarding depression in 2006. And now we're going to go into the common side effects of quetiapine. So quetiapine, like I mentioned, is classified as an atypical antipsychotic and is generally better tolerated than older high potency drugs like haloperidol. But then quetiapine, as any other uh, pharmaceutical drugs, come with some common side effects. One of the most common side effects for quetiapine is actually sedation, which can be helpful for people struggling with anxiety or insomnia, but it can also cause daytime drowsiness. And then just even thinking about older adults maybe who maybe have bladder problems, even this can cause this can be kind of like a side effect because like if let's say in the middle of the night they need to get up and go to the restroom because quetiapine has a high sedation mechanism of the way that works is high sedating, then if somebody needs to go to the restroom it might be hard because they will be drowsy and dizzy. So then this is something to kind of keep in mind and thinking giving this drug to maybe older adults or even younger adults. Another common side effect is it also has an anticholinergic effect, which is why patients often report dry mouth and constipation, weight gain, and increasing appetite, especially increasing appetite. So then it's recommend some providers recommend patients to kind of know that they will have hunger, and so then to kind of take proper measures in regards to this. And this can contribute to metabolic issues like insulin resistance or even diabetes if not monitored. So it is very important to, whenever this drug is administered, to kind of keep in mind of like all these other medical concerns that can come with these medications. Another key side effect is orthostatic hypotension, which I mentioned earlier, which means like the blood pressure that the blood pressure drops when standing up too quickly, so patients might feel dizzy or lightheaded. And so then these are common side effects that we need to be aware of. And so then, while quetiapine is generally well tolerated, it is important to be aware of some serious risk. So first, it can contribute to metabolic syndrome, which includes weight gain, so kind of going into high cholesterol and increasing risk for diabetes, as I mentioned before. That's why it's important to regulate, kind of like going into lab work. A rare but life-threatening side effect is the neuroepileptic malignant syndrome, or NMS, which can present with muscle stiffness, fever, confusion. Another one is the tardive dyskinesia, another serious concern, which involves involuntary movements, though it's less common with quetiapine than with the older antipsychotics. But then there's also kind of like, there is some risk, so something to consider. There is also a black box warning for suicidal thoughts in young adults, especially in the first few weeks of treatment or when adjusting the dose. So it's kind of like good to keep in mind on that sense. On a more positive note, quetiapine tends to cause minimal prolactic increase, which is a benefit compared to some other antipsychotics that can cause hormonal issues. And now moving on into breaking down how quetiapine works in the body over time. So first, half-life refers to the amount of time it takes for the concentration of the drug in the bloodstream to drop by half. So this kind of helps determine how often the medication needs to be taken. So for quetiapine, the immediate release, which is IR, form has a half-life of about 6 hours. And then the extended release XR form lasts slightly longer, about 7 hours. And it's an active metabolic. Norquetiapine has a longer half-time of around 12 hours, which extends the medication's effect. So then I guess the benefit of this extended release version is that it helps maintain smoother and more consistent blood levels, which can reduce side effects and improve adherence by requiring fewer dozens throughout the day. So then the dosage depends on, it's based on the condition being treated. So these are just some examples that I wanted to share. So for schizophrenia, the dosage usually ranges from like 500 to 800 milligrams per day. And this is depending on the severity and how the individual responds to the dosage. In bipolar disorder, both manic and depressive episodes, these are treated within like kind of the same general range, which is like as schizophrenia, 50 to 800 milligrams per day, with kind of adjustments made based on phase and tolerability. And then for some providers, the most common milligrams that they start on is 100 for bipolar disorder. And then kind of like depending on how the patient is tolerating, and then also like how their symptoms are improving, not improving, they will adjust accordingly. So for major depressive disorder, quetiapine is used as an adjunct treatment, so meaning is added to an existing antidepressant. So these dosages are lower, typically between like 50 and 300 milligrams. So These ranges help tailor treatment to each person's needs while balancing the effectiveness and keeping in mind these side effects. And so then we already cover side effects, high risk. And so then when should quetiapine should not be used? So then just thinking about if a client or a patient is hypersensitive to quetiapine and they have already developed an allergic reaction, um, like a rash, swelling, or difficulty breathing, then it is not recommended that they should take these medications for the serious risk of reaction, even going into an anaphylaxis shock. Second, quetiapine is not recommended for the elderly patients with dementia-related psychosis, and especially because this group has a higher risk of stroke and death when taking antipsychotics, and so there's an FDA black box warning for this population. And finally, quetiapine should not be taken with strong as the CYP3A4 inhibitors. These medications block an enzyme that normally breaks down quetiapine in the liver. So if this enzyme is blocked, the drug can build up to dangerous levels, increasing the risk of sedation and toxicity. And so some common CP3A4 inhibitors include antifungals, antibiotics, some antivirals, and even grapefruit juice, which can interfere with metabolics. And so just being aware of these interactions is crucial for prescribing safely. And lastly, I just wanted to highlight some cultural considerations when prescribing quetiapine. I just want to know that it's important to know the stigma, spiritual resistance of medications, and especially in communities with mental illness. So it's just to keep that in mind. Um, and then framing medication as a tool that God or a higher power can use for healing can build trust. Also, the language and like the health literacy are critical. So many patients may not fully understand what their medication is for. So kind of taking the time to explain and provide psychoeducation in the client's own language can go a long way. So then using culturally relevant language can help, can make a difference into adherence to medications. And just thinking about even collectivistic cultures, family play a big role into like health decisions. So then even if somebody is going to provide or treat someone with quetiapine, it's important to kind of process with the client what would it be to kind of include their family in it, or kind of bring them in for a psychoeducation as well. And finally, consider the financial access. Some patients may not be able to afford quetiapine, especially those without insurance. So kind of offering generic alternatives and connecting patients to maybe assisting programs can help ensure continuity of care. So now going into the case presentation, Maria is a 70-year-old Nicaraguan Spanish-speaking heterosexual. She's gender female with a long history of substance use, sexual trauma, and multiple psychiatric diagnoses, including schizophrenia, bipolar 1 disorder, PTSD, and major depressive disorder. So she's seeking clarification about her diagnosis. Some of the clinical observations include tangential speech, disheveled appearance, minimal eye contact, and reports on beliefs of the cosmos that this is kind of what kind of helps her go through her treatment. And so then right now she's experiencing concerns with sleep, irritability, and mood swings. And so she has no history of psychiatric hospitalization. Maria shares with you that the people often kind of has labeled her as loca, which means crazy, and she just feels kind of this. She has a sense of despair for being prescribed so many different medications like Depakote, Abilify, Trazodone, and she just feels, and she kind of like has been doing her own research. Um, And then kind of she learned that some of these medications are for schizophrenia. So then she's all like, I do not have schizophrenia. So then she comes to us kind of just already mistrusting her current psychiatrist, especially because um, language barrier. He only speaks English, so he uses like the translation communication in order to explain. So we can see the barriers in that. So for Maria, I will consider starting on Quetiapine, adding like 100 milligram, giving her current symptoms and a clinical history. It is a good option because it can help with sleep issues, mood swings, and irritability, which is what she's reporting, and then also a history of depression. So Quetiapine seems to kind of like go into that route of like maybe support her. And it has a lower risk of EPS. And then, as we know, that she is an elderly adult, so I feel like quetiapine will be helpful, which is important for, like I said, like an older adult. So Maria, she shared that she has previously prescribed multiple medications, and so then it's just because of the feelings of overwhelm, uh, using quetiapine will help her with like maybe taking one medication rather than taking so many, and this can decrease the side effects and then the drug interactions, and maybe kind of help with treatment feel more at ease, and more kind of also reduce the emotional burden and kind of improve her adherence. So in therapy, I will provide some education to help her better understand her symptoms, and especially in her language. I'm thinking about maybe CBT can explore like the challenge her core beliefs, especially doubts about her diagnosis, and then also like her core belief of feeling like she's crazy. I also coordinate with her. If I'm the psychiatrist, I will coordinate with her Spanish speaking therapist to maintain continuity of care, and then just hold the collateral sessions where she can ask her questions. And since she already has a rapport with the therapist, then it could be a easier way to kind of like address her concerns, and for the therapist to be able to explain what's going on, and even like clarifying her diagnosis that mm, that she does not meet criteria for schizophrenia but bipolar 2, since there was no hospitalization, no sign of mania. And so then lastly, I would just focus on building her coping skills and strength, helping her feel more empowered in the treatment process. And thank you for your time.